And the reason that they had sort of brought this forward was that they were saying, well, a lot of people probably have this. There were literally only 58 cases described in the literature. Right. A lot of people probably have this and don't know about it.
Right.
And, that worked because
they were saying maybe as many as 1 in 4,000 men.
Yeah.
That's not rare. 1 in 4,000 is, I don't know, do the math.
Yeah.
That would be thousands of people just in the U.S. with that condition walking around not having a diagnosis. So there's another thing that unless you're doing the right steps and you're being super thorough and getting all the information that the science of today allows for, you'd miss it.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. Enjoy the show. Today's episode is sponsored by Biography Health, where healthcare meets personalization. With their DNA-enabled blueprint, Biography Health empowers you with a health plan based on your unique DNA, aiming to prevent disease and extend your life. Take control of your health journey with a plan as unique as you. Visit biographyhealth.com and start your personalized healthcare journey today. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine. For this episode, Dr. Bretsky shares a remarkable case study that unravels the complex relationship between genes and inflammation. When a patient's mysterious symptoms led to the rare diagnosis of VEXAS syndrome, it revealed an unexpected connection with cardiovascular health, demonstrating how different genetic factors can interact to amplify health risks. Hey everyone, welcome to the Precision Medicine Made Simple podcast. I'm here with my co-host, Dr. Stanford, and then also a guest you've been familiar with beforehand, Dr. Bretsky. And for this episode, Dr. Bretsky is actually bringing a very fascinating case study that, I'm going to be honest, as I was looking through the notes, I was trying to understand what was going on, and I was in ChatGPT, helped me out just a little bit. So I have a number of questions going into this, but welcome back. Thank you so much for coming back.
Yeah, thanks for having me. It's good to be here.
Yeah. Well, so I guess to get started with this case at a high level, what happened with this person?
Yeah, so it's a very sort of interesting case that I think is helpful in illustrating sort of gene and sort of other gene interactions. So I think a lot of what we talk about, and also too on the very traditional platforms looking at genetics, whether it's BRCA1, BRCA2, ApoE, we're talking about sort of like a single gene and then an outcome. And we don't really talk about how the interplay of different genes in the body can occur. So one of the classic sort of mechanisms in cardiovascular disease that I think everybody's familiar with is CLOG, which is high cholesterol. And within those kind of cholesterols, there's really the nasty one, which is this LP little a, or lipoprotein A. The other mechanism that I think a lot of people don't talk about, but is probably equally important in cardiovascular disease, is inflammation. Classically, the best way, in quotes, best way to get inflammation is to smoke. And so if you smoke and have high cholesterol, you then get this much higher rate of cardiovascular disease than you would if you just smoked or just had high cholesterol.
That came just with two basic questions then. I'm assuming it doesn't matter the type of smoke, whether you're smoking marijuana or tobacco. Well,
actually, it does. Yeah,
okay.
I mean, it does. So, I think marijuana doesn't have the same sort of pro-inflammatory elements that tobacco does. Vaping, actually, interestingly, has the same amount, if not more, pro-inflammatory. So the idea that sort of vaping is safe smoking is really not the case. But yes, traditionally, tobacco. Also, too, the amount. I think if you could smoke 20 cigarettes in a day, I don't really think you could actually get through 20 joints in a day without being catatonic. So in terms of
my roommate in college could do it.
depending on your level of tolerance. Right. So yeah, the other sort of pro-inflammatory thing too is is like charbroiled meats. As well. So dietary inflammation from diet. And then in this particular case that we'll talk about, the pro-inflammatory state is actually from an autoimmune process. So we would see that in certain kinds of things, like rheumatoid arthritis, potentially like lupus or other autoimmune processes.
Right. And before we dive into the autoimmune process, then you mentioned Lp(a). And I'm not going to lie, I kind of flubbed when I had an uncle that was in the hospital. He actually had a heart attack. And I was reading Outlive, and I asked the nurse, I was like, dude, trying to sound smart, or trying to figure out what the case is. And so I was like, oh, what is his Lp(a)? And the nurse didn't necessarily know it. And I don't know if I just asked a really dumb question either, but if we were going to break it down, what does that mean? I know it's pretty common in both of your fields, and it's always talked about, but for somebody that doesn't know, what is Lp(a)?
And fold into your answer, what percentage of doctors do you think check for Lp(a)?
Yeah, that is a great question. I mean, I think from my cardiology colleagues that expressed surprise as a primary care provider that I check it, I would guess probably about 20%.
Wow.
So,
and the rationale is that there's no treatment for it, so why check it?
I think that's been the sort of traditional rationale, although there are treatments now in clinical trials.
Right.
And so, some of, at least what I try to do with folks is if there are clinical trials available, we try to get them into those, for stuff that would be helpful.
And certainly if you knew the Lp(a) was high, you would want to make sure the other treatable factors were minimized. There might be extra incentive.
Yeah. And Lp(a) is highly genetic. And it's not traditionally respond to statins or cholesterol lowering medications like Lipitor or Crestor that we use. And to that end, it's difficult, to do much about it. Although I think, exercise certainly, will be helpful in that. And as Dr. Sanford said, reducing the other cholesterols that people are more familiar with, like LDL and VLDL, would be helpful.
And I guess PCSK9 inhibitors will decrease it 20%.
Right. Yeah. So that's those are the newer sort of like Praluent and Repatha, which are injectable every 2 weeks.
But these new drugs, these interfering RNA drugs that Philip mentioned is will reduce them 80% or more. Right. So it's going to be an amazing breakthrough drug. I don't hear people talking about it that much.
It is, yeah. I don't really either.
Yeah, so. I mean that's going to be a huge breakthrough. And what percent? Do you happen to know what percentage of people have a LPA gene variant that would cause them to have?
Not off the top of my head, but from a sort of an informal survey. I run it as a part of the routine annual examination. And so what's interesting about it is sometimes you'll get folks that have like high LDL and they have an undetectable Lp(a). Generally, I don't generally see people with, spectacular LDLs and high Lp(a)s. There's usually some correlation there. So I would guess sort of in the population level, probably 5 to 10%.
Yeah, that's what I was going to say.
Yeah.
But if you did, let's say you did have a genetic predisposition for high Lp(a), so like, for example, I had my polygenic risk score, thankfully to Dr. Sanford and Biography Health, my risk of a Lp(a) was elevated. And then, so that means because it's elevated, I have a higher risk for heart disease, cardiovascular disease, really bad cholesterol.
Yeah, we call it the sort of the horrible cholesterol.
Okay.
And then again, there's not too much to do with it. And by the same token, it doesn't change a lot. So when you measure it, there'll be some fluctuations. I've had a handful of patients where I've looked at it maybe for 3 years running, and there'll be some movement within it, but not much.
Got it. And so if you measure this, then at least you can go into this direction and try and discern what's actually going on and try and break down. And now bringing this into this case, then did this person have high LP little a?
Yeah.
What's the story here?
Yeah. So the story of this particular case is actually is really fascinating. So the pretty healthy, 70-year-old male, and slightly high cholesterol, but actually like not on any medications, and had a sort of this very dramatic presentation where he actually, interestingly enough, came in with testicular swelling, which is unusual. Testicular cancer is usually like sort of late teens to early 20s. So so you think about other things when somebody comes in, most usually at that age, like would be like a hernia or some sort of mass like in the kidney that's kind of backing up flow. That actually got better, and we never actually found a fabulous explanation as to why that happened. But soon afterwards, he got very, very anemic, and then had difficulty with what we later figured out was called allergic alveolitis, which was basically a profound allergic reaction in the lungs. He responded to steroids. He had to go into the hospital and get blood transfusions and things like that.
Did his hemoglobin come up with steroids as well?
Yeah. So his hemoglobin, a normal hemoglobin is about 11 to 16, in a maybe 12 to 16 in a healthy male. His went down all the way to 7. So he essentially kind of lost half of his blood volume. And so when you see that happen and somebody's not actively bleeding, I mean, your first thought
is there's no hemolysis.
Right. Yeah. That he's got a cancer, right? That something has basically infiltrated into the bone marrow and squeezed out kind of all the other cells that make, the stem cells that make red blood cells and down the line. But actually, when we did a bone marrow biopsy, and the bone marrow was there was no cancer in there. So we were really, really flummoxed.
Right.
And so, and steroids are kind of like, the easy, I call them the dummy answer, with, physicians being the dummy. Like, it works. We don't always know why. And in this case, we didn't know why, but he had this sort of multi-system involvement, where his hematologic markers were off. And then he had this really profound allergic reaction, and such that he was needing inhaled steroids and very short of breath. So we eventually sort of cobbled him back together, and sort of then went through like, okay, what happened? And so with cancer off the table, we then thought about something called Waldenstrom's or macroglobulinemia, which turned out he didn't have that either. And so we sort of were like, he's on a standing dose of steroids, which is not a great long-term solution. And every time we tried to kind of lower them down, he'd get sick again. So so we were kind of in this in this strange kind of holding pattern where he was out of the hospital, living his life, but then needing this medication, and he, again, somebody who hadn't needed anything before. So like all good, sort of diagnoses are usually made by, serendipitously. And so his wife brought in an article from CNN talking about this phenomenon called VEXAS syndrome, which is an excellent.
So you're saying VEXAS, like Texas with a V.
Exactly.
Or Vegas with an X.
and I meant to look this up beforehand. What does that acronym stand for?
So it's like vacuole, X-linked, autoimmune syndrome.
Oh, there you go.
So vacuoles are these sort of little.
Well, it's really an auto-inflammatory.
It is actually, yeah. That would be more of an accurate a statement. And vacuoles are the kind of these sort of packaging materials that are within cells. And so she brought in this CNN article about, and it's X-linked, so it only presents in men, because men have XY, and so if there's something that's on the X chromosome, it's going to express, whereas women have 2X.
Like color blindness.
Right. Yeah. So, anyway, so I was like, well, we have no idea what it is, so this might as well, this is as reasonable of an idea as anything, and a lot of it fit.
I thank you for sending that link. I clicked on it. So that guy also presented with how did he say? Something in his in his male Netherlands or something.
Yeah,
Some euphemism for his junk,
Right.
and so they did have that in common.
Yeah, exactly. Yeah, so this was picked up by CNN, and there are two researchers actually who were then at NIH and they're now at NYU. One of whom is a rheumatologist, and rheumatologists, basically specialize in these autoimmune processes. And the other is actually a benchtop scientist, and the two of them kind of work together. And they're the reason that they had sort of brought this forward was that they were saying, well, a lot of people probably have this. There were literally only 58 cases described in the literature. A lot of people probably have this and don't know about it.
Right.
And that worked because
they were saying maybe as many as 1 in 4,000 men.
Yeah.
That's not rare. 1 in 4,000 is, I don't know, do the math.
Yeah.
That would be thousands of people just in the U.S. with that condition walking around not having a diagnosis.
Yeah. So I was like, well, this is as good an idea as any. And so, and we sent off a sample to actually down to Invitae in San Diego, and it came back with the gene. So
that was going to be my first question. So that must have been blood you sent to Invitae.
Yeah.
Okay, so this may not have been picked up with a cheek swab, and in the literature that you gave me beforehand, it's a somatic mutation,
right,
and not a germline mutation. So it's not something you're born with, it's acquired.
Right.
And so it's only going to be in myeloid cells, right? But myeloid cells affect a whole lot of body systems. That's how you could have this one mutation in one cell, and it affects so many different things.
Right.
So it would not have been, you'd have to be sequencing white blood cells.
Right.
In order to get it.
Yeah. And that was part of the reason, we had sort of sent that there as a sample, as well, because again, he had this sort of suddenly onset at the age of 70, would be unlikely that would be something, although it's possible if it could be germline, but we were thinking, and again, specifically, if we were looking specifically for VEXAS,
you were looking specifically
exactly at that point. Yeah.
Now, if you can break this down for me, since it's not inherited, then how does somebody get that?
Well, it's probably an accumulation of sort of insults like ultraviolet light or other sort of mutagenic things in the environment. Yeah, that affects that area.
Vaping.
Okay. So it's a lot of environmental factors that then come into this. And then, is there a special test that you would, you mentioned white blood cells, in trying to test for that. With whole genome sequencing, we do the BRCA swab. Would that...
Which is epithelial cells, which probably don't have the mutation. So it's only a mutation in those cells that come from the fancy word is hematopoietic. Okay. So bone marrow cells that make your red blood cells, that make your white blood cells. So you would have to then probably just white blood cells, right? It's the only place you would see it.
And that's, again, that's with the presentation with the low hemoglobin, that's how that sort of gets involved. And that's, we actually did it again, like looking for cancer, a bone marrow biopsy. So you're really looking at the source of those cells.
So one question might be, when we do these buccal specimens, would that pick up a mutation in white blood cells? And the answer is probably not. So, yeah, it's just an interesting thing.
But if you were to go down the pathway of thinking, okay, I'm going to, let's say, do whole genome sequencing, take my swab, and then figure out what my genetic risk factors are, and then kind of go down this pathway and then look at the labs, and then that's how it's consolidated into getting to where we are testing for these white blood cells.
Right.
So looking at whole blood with the white blood cells in it is literally a biopsy in this case. It would be like as if you went into the tumor, took a chunk, and then looked at the DNA for mutations associated with a tumor, that would be similar to looking at blood and the DNA in white blood cells and looking for mutations there. I hope that wasn't too confusing.
Right. But the one thing the buccal swab would have picked up is his LPA.
Yeah, which gets into the gene interactions you wanted to talk about.
Right. So I think we would have, gotten at that again. And when we looked at his LPA as we sort of worked through this, pro-inflammatory or auto-inflammatory process, that then, from my perspective, made like what are his cardiovascular risks that much more important, and right, because I knew that he has this intense inflammatory process going on systemically, and so a normal LPA is under 75, and his was 221. So again, with the timing of when he had this pro-inflammatory state. Again, his LPA has probably been that way, his entire life because it's genetically loaded. Now he's got the environment within his body to start depositing that.
Right.
And inflammation, again, whether it's through smoking, vaping, an inflammatory process creates what we call endothelial dysfunction, which is basically a perturbation in the cells that line the arteries.
Yeah, think of it like a lining of a pipe.
Right, and that then gives the substrate or the sort of the right impetus then for cholesterol to start to stick.
So those particles can get in there.
Uh-huh.
And then they become inflammatory in themselves. So it's kind of like inflammation begets inflammation.
And this cascade happens.
But, and a bigger part of this, and this has come up in a couple of cases through the years. So, and one just at dinner the other night, lady with scleroderma.
Right.
But she's, that kind of a persistent inflammatory state is an additional huge risk factor for heart disease. So if you're looking at someone's genetic risk and even looking at their lipids, you have to look at people that have had an autoimmune disease or autoinflammation or inflammation for any reason. Your index of suspicion needs to go up. And this particular person had actually had Prinzmetal's angina, which is thought to be associated with endothelial dysfunction. So all the way back 30 years ago. So my fear for her is she's had this ongoing inflammatory process, which we know manifested at least once in her coronary arteries. And, I don't think anyone's really ever looked at it.
Yeah.
And I said, or let your cardiologist better start helping someone connect these dots.
Right. And then the similar sort of analogy then too with diabetes, which we treat type 2 diabetes as well as a coronary risk equivalent. So you basically treat them in terms of their goals of their cholesterol are, blood pressure and things like that, as if they have already had a heart attack.
Right.
Because they're at such high risk. And again, with the circulating higher sugars, that's also a pro-inflammatory process. That's just bad for you on a lot of different levels. But your index of suspicion and then your requirements for where they are in terms of their biometrics, really become a lot more intense. And I think that's where, that's really neat then in terms of the stuff that biography is doing, because you have the capacity then within the software system and within the platform to build in those numbers, and not only as a static thing but longitudinally as well. Now LPA is probably not going to change a lot until those drugs are on the market, but you can look at people's LDL levels, you can look at their A1C, you can see how those are improving. But for this person, this individual, his LPA, even if it was high before, it got really high because now he has a mechanism to stick it into the coronary arteries. And I think this is kind of really where precision medicine, now the ball starts to roll. Right. Because traditionally you'd look at his LDL, you'd be like, okay, it's 125. It's not horrible. Maybe you think about a cholesterol lowering medication and he's off to the races. What I did was like, oh gosh, he's really set up for heart disease. So I sent him for a coronary calcium scan.
Yeah, why don't you take us through what you did for him? And one thing I do want you to mention is like his ESR and CRP, were they elevated?
They were, they were elevated during, sort of the presentation.
Yeah.
So ESR is a sedimentation rate, C-reactive protein, CRP. And actually there's a cardiac specific CRP as well. Then I will run that in patients to get at this idea of inflammation influencing heart disease. So you can have a global CRP, which is basically how annoyed your entire system is, and then a heart-specific C-reactive protein, which is like how annoyed is your heart, which is, again, these are really kind of interesting and cool metrics.
So you're going to take us through. And was the first thing the VEXAS diagnosis?
Yeah, so that was,
and that's before you picked up on the Lp(a).
Yeah, that sort of all kind of came together because at that point, I really was like, okay, we've got a confluence of events kind of going on. How I approach patients in these sort of events is there's an acute phase, whether, when something bad happens, you get them through that acute phase, but you really have to make a plan for this like longer term chronic phase. And again, we knew that he had this autoinflammatory process. We had a solution, even though it wasn't a great solution. And then, so what is the next step there? Like, well, how do you keep him healthy? Kind of what's your next risk? And so in a highly, inflammatory process like that, the cardiac was sort of my first thinking. In other, processes like maybe like rheumatoid arthritis, you might be worried about osteoporosis or, difficulties with bones. But in this case, I was really kind of focused on his cardiac risk.
And so what'd you do?
So then we sort of back out and kind of did a full, annual panel for him, which would, include his sort of basic blood tests. And then an advanced lipid panel, which includes the traditional stuff. So total cholesterol, LDL, HDL, triglycerides. And then within that, kind of the subparticles. Right. There's LDLP, LDLC, and then ApoA and ApoB, and then Lp(a). And like I said, sort of he had sort of slightly, not perfect LDL. Same with his ApoB, which is kind of like I use as like an aggregate measure of the bad cholesterols. But the Lpa was what really stood out. I mean, that was, again, like I said, normal 75. His is 221. So you're 2.5 times normal. It'd be like sort of coming in with a cholesterol like 450.
Have you ever seen one as high as
I have? I've had a couple that are that high. Yeah, but
that's about as high as I've seen.
Yeah, that's really high. Some I'll have some folks in the low 100s. But yeah, 221 is pretty impressive. And you would expect that he'd have a family history chock full of heart disease, which he doesn't. So again, maybe that's because people didn't live long enough to get it,
right?
Or they didn't have that secondary sort of pro-inflammatory process to lay it down. So
it's complicated.
Before we get into that second part of the process, then if like in the general healthcare system, if they're not Dr. Bretsky or Dr. Stanford, then would that patient need to advocate for that advanced lipid panel? So like what is the patient or would the doctor say, yeah, you probably should get an advanced lipid panel and actually look for that? Like would it be the patient's responsibility to try and bring that up, even though I guess the patient wouldn't really know about?
Yeah, no, I don't know. You take that. You're the primary care doctor.
Yeah, I mean, I think the short answer is no. That's not going to get run. And I think the rationale, which isn't entirely unreasonable, is that, well, there's not a treatment for Lpa. So why would we really look at it? But again, with clinical trials kind of going on.
But also in a Bayesian kind of way where you take all these pieces of information. So even though you can't particularly act on that, it would influence how you look at everything else.
Right.
So yeah.
And there's that whole, Francis Bacon, knowledge is power kind of thing, right?
Right.
So yeah, and I think, but for me, in terms of as I started doing more of the Lp(a), I did it for two reasons. One is because I, could then say, okay, we've got to double down on these other measures. Two is I, sort of knew that the clinical trials were coming up. And then the third part then too is a little bit of a nuance in the coronary calcium. So people with LP little a, I actually will run a CT coronary angiography, which is kind of the coronary calcium plus, just because it can be a little bit tricky. And you have the suspicion that this horrible cholesterol, that they're going to be more likely to have something. So I run that sort of more detailed look, because going into it, I have a higher suspicion that they're going to have some plaque deposition, and I'd like to know where it is.
And it really, from what you shared with me, his disease, the luminal disease, was out of proportion a bit to his coronary calcium score.
Right.
So you can see how this guy could be missed in the current healthcare paradigm. You don't check LP little a. You do a half-assed family history. You don't connect the dots on this autoinflammation being an aggravator, and you don't go the extra step of getting the coronary CT angio. So you could be, let's say, as you described, not much family history. Oh, good. He's got some weird systemic illness. Okay. His lipids look okay, not under treatment. No one's concerned.
Right.
And coronary calcium was like 70th, 80th percentile.
Right.
Not great, but So until you start doing this extra stuff and picking up this extra information and doing what Dr. Bretsky did, which is connecting these dots, then once you start connecting the dots, you go, oh my God, there's probably something really awful going on. And so you did, and then what?
So with that, I had a high enough suspicion, from all of that, as well as his coronary CT angiography. So I actually then did what's called the myocardial perfusion scan, where you're actually looking at blood flow through the heart, and myocardium being the fancy word for heart muscle, and perfusion basically being blood flow. And so when I got that back, it showed a 12% reversible. That's kind of the key word, that it was reversible deficit. So when he's stressed, when the heart is working, 12% of his heart was not getting adequate blood
That's
flow.
a big chunk. Oh. That he had chest pain with that?
Nope.
So there's another thing, that unless you're doing the right steps and you're being super thorough and getting all the information that the science of today allows for, you'd miss it.
And then your next call, when you see that, is to your favorite interventional cardiologist. Like the second that came across
Who's
my
your
desk.
favorite interventional cardiologist?
So in Santa Monica, I use Prab Brara. Okay. And Prab I've worked with for a long time. And Prab is cool as a cucumber. And I called him in a panic, and he was like, all right, we'll see him in 3 weeks. I was like, wait. So, but no, but he doesn't flinch. So, yeah. And we're fortunate here, between, and also, we have a lot of really great.
So Phil saved
cardiologists.
12% of this guy's heart.
Wow. Well, actually, technically, Prab did. So.
No problem. Well,
if you didn't make the call.
That's true. True.
You were God here, so to speak. Prab was just the technician.
So what was interesting about it is when Dr. Brara did he did what's called a coronary catheterization, and they basically take a wire up either through the femoral artery or through the radial artery. When they do it through the wrist, it still freaks me out. They can actually get to the heart through the wrist, which is like...
Because you're thinking that,
right.
Femoral artery, we've all felt your pulse. It's
right.
Like, you can feel that.
How do you get a wire through there?
Yeah.
It's wizardry. So my thinking from actually the imaging and stuff that we'd had before was that the major issue was in what's called the left anterior descending, which is kind of the major...
The widowmaker.
We call it the widowmaker. Yeah. And then there's very characteristic changes on the EKG when somebody's having a coronary event. And the EKG, everybody's familiar with the tracing, where it's and then you can see it on the side of ambulances and things like that. But there's something called ST segment elevations.
We're going to have an ambulance company with a logo with tombstone ST elevations.
And that's what we call them. We call them tombstones because they actually look like a tombstone.
And you're going to need a
and
tombstone.
You're going to need one if somebody doesn't take care of
quick.
it. So, but what was interesting is when Dr. Barra did the catheterization is it actually was his right coronary. That was the what we call the culprit lesion. So, and I don't know again if this is related to the interplay between the genetics and LPA where it's depositing, or if it's related to his own anatomy. But he said it was as he got through in there, just even the wire, and they use a wire then and put a stent, which basically opens up the artery. Over that wire, but just the wire would cause on the monitor ST segment elevations. So he would cut off the blood flow just with the wire. It was that tight, and so what they do is they're able to open that up, get blood flow through there, and restore that. And the key word on the original one was reversible. Yeah. And this, which meant that it was probably fairly new. I don't know, how long that had been there. But if it's stuck there for a long time, you can't reverse that. That tissue doesn't come back. But his was reversible, so he should have full function and be able to do all the things that he did and wanted to do, and not worry about having an event where that process of then stenting that and opening up that clog would be done under an emergency situation. As opposed to a controlled, plenty of time, everybody's stable, and you can do it without rushing.
Go
ahead.
No, this might be a very dumb comment. But we'll see. So now bringing it back to the beginning, then did the testicular mass go down?
Yes.
Okay.
Yeah.
Okay.
Yeah.
Yeah.
Well, the part I find interesting is that the index case, so to speak, the CNN case, the guy had a testicular mass also.
Yeah. And I'm wondering if that maybe was like a vasculitis or something. So basically, one of the things we see in autoimmune and autoinflammatory syndromes is actually the vessels get inflamed. And similarly, as we talked about endothelial dysfunction, which is the sort of the inside of the vessel, the vessels themselves can have inflammation, and then it sort of cuts off blood flow or impedes blood flow, and then allows kind of the fluid component of blood to leak out. So I don't know if it was like a vasculitis or something. Obviously, in the testicular area has a lot of blood flow, and so but that got better, and so that sort of left us, scratching our heads at the time in terms of what that was.
I can't wait to. So as soon as I get home today, I'm going to take my open AI. I'm going to go testicular mass goes away with steroids. Pneumonia improves with whatever.
Right.
And see if VEXAS comes up on the differential.
Be interesting to see. So and then the treatment of the VEXAS is actually, we're using a biologic agent called Actimra, which we use for something called Behçet syndrome. As well, and but this is all very new.
Which molecule is that targeting?
So it's one of the I think it's the IL-6 cascade. So it's not, there's the sort of more the traditional biologics like Rituxan, which we use like in inflammatory bowel disease. We actually use in some
it targets TNF-alpha.
TNF-alpha, yeah, and so which is part of again this inflammation cascade. The Actimra is a sort of a more specific one as well. I have not been able to get him off steroids completely, but able to reduce it.
Even with that?
Even with that, yeah. But went from about 60 milligrams a day down to about 10. So a normal amount that the adrenals make is about 5 milligrams a day. So we still have him on some excess, but
so is the cure being considered a bone marrow transplant?
So I don't know if they've sort of gotten that far in terms of how you would cure it as well too. And again, I think also too the presentation of this, and this is also in the literature of the described cases as well as that CNN article. You were talking about men generally in their 70s. So, bone marrow transplant, in that age,
That's a lot.
It's not impossible, but it's a lot. Bone marrow transplant involves basically just completely eliminating your entire immune system, and to the point where you can't even have flowers in your hospital room, and then finding an appropriate, donor, and then rebuilding everything from there. So that is not an easy therapeutic process, even for somebody half 70.
So what kind of dose of steroids is he still on?
So he's still on just about 10 milligrams a day.
Oh, okay.
Yeah. So not a huge amount, but every time we try to bring him down, his symptoms start to come back in terms of some of the shortness of breath and stuff like that.
So now getting on the preventative side,
Right.
then considering all of these different factors that have happened, where would one start then to try and, granted, this seems like such a rare, I guess semi-rare in a way, but
Yeah, no, it's rare.
Rare.
1 in 4,000 is still rare. It's just not that, orphan thing where there's like 5 cases in the whole world kind of thing. You figure 1 in 4,000. In other words, it's rare but not unusual.
right. So, rare, not unusual, something that I guess, like for me being 29, me being 29, don't want to worry about something like this going into it. But if, let's say, I did have, I guess, the biomarkers and that led up to this, how would I prevent something like this from happening?
Yeah, I think, again, and I think that's some of the idea there of these interactive effects, that basically, traditionally, again, we've kind of looked at sort of one gene, one outcome. Again, you'll sort of start to get an aggregate measure with some of the polygenic risk scores that you see on with biography, and you just have to be aware, right? Like, and you have to be, you're like, okay, somebody is more likely to develop, this outcome, whether it's cardiovascular disease, whether it's, neurodegenerative disease, whether, it's cognitive decline, metabolic disease. And then if something changes, I think this is where it's important to kind of know your patients, right? Like, something changes in that landscape. If you keep doing the same things, you're not gonna pick stuff up. And so, and again, it's a little bit of what I alluded to with the diabetes being a coronary risk equivalent. So you have somebody that's in with, type 2 diabetes, even if it's well controlled, you really need to have them on a cholesterol lowering medication.
Right.
That's part of the standard of care, but not everybody's on it. They should be on a baby aspirin unless there's other reasons to not be on it. And they really should be having a very thorough cardiac workup, including, a coronary calcium scan, the stress test, maybe a myocardial perfusion scan, because again, the assumption there is that they have already had an event. Diabetes is sort of well known for the silent heart attack and things like that. So you just have to be vigilant, but kind of knowing what your baseline risk is, then empowers you as a patient to say, hey, I have this, LPA, gene, or I have this risk factor or this confluence of risk factors. Maybe should we look at an advanced lipid panel, and should we look at that kind of moving forward? I know from Peter Tia's book, The Outlive, he's a big proponent of ApoB as kind of this kind of aggregate measure of your bad cholesterols. So that's, you have multiple kind of ways at it. And you just, again, want to make sure with the biometrics that you're looking at it. You don't have to look at it perfectly, but you can look at it in a couple different ways.
So if I'm advising a 29-year-old that wants to avoid things like this, right, as part of the genesis of your question, you want to avoid oxidative stress and inflammatory states, right? So smoking, don't smoke. Obesity, don't be obese. Diabetes, insulin resistance, those things tend toward inflammatory states. Don't eat foods with added sugar. and wear a continuous glucose monitor from time to time just to see how you're doing. Exercise. Tons of things that you can do to reduce those inflammatory states and oxidative states in your body, which are mutagenic. So will cause mutations like this. So really, when you think about this disease, it's kind of similar to a cancer, really.
Yeah.
It's really similar to a blood cancer. You've had a mutation, in a stem cell in your bone marrow that is now just raising hell throughout your body. And by the way, that inflammatory state in itself is driving things like neurodegenerative disease, is driving you toward metabolic derangements, is driving you toward cancer risk. So he has additional cancer risk just from having this steady state inflammatory condition.
And that was originally what we thought. We thought it was a cancer, which is why we kind of did a bone marrow biopsy. And then following up on Bill's point too, in an advanced lipid panel, you actually get an insulin resistance score. It's a 5 level stratum. And that's always really interesting when I go through patients with that, because you can see sort of who is on the pathway for metabolic
How do
disease.
you like that thing? I always see this kind of disconnect
really weird.
between that score
Right.
and someone's fasting insulin. Like, I can look at someone, look at their insulin.
Right.
I don't need that to tell me the person's insulin resistant.
Right.
But then that score comes back and they're like a 1 on a
Right.
scale of 5. I'm going, yeah, I don't think so.
It is funny too, and it's part of the cholesterol panel. So I'm like,
Yeah.
wait, who decided to put a sugar measure in a cholesterol panel? So yeah, I use it as sort of an adjunct. I do check people's insulin levels as well. And actually, with the advent of sort of Ozempic and Wegovy and Zepbound, having those levels and following them as they address obesity or their metabolic syndrome is really super helpful.
Yeah.
So that is actually something that you would encourage physicians to add. Would be a fasting insulin as well. But it is funny, the LPIR, or the insulin resistance score that comes up. There is sometimes a disconnect. So sometimes I'll see people with high hemoglobin A1Cs, which is like a 3-month average of their sugar, and then they have very low insulin resistance scores. My out on that with what I'm telling people right now, we'll see how it works.
Good, I want to hear it,
As
because I haven't come up with an out on
I said,
that.
it's what
I just stopped ordering the insulin resistance score.
Well, what I'll tell patients is I'll say, okay, you're not necessarily prone to insulin, but you're eating something wrong, right? Right? Because how else can I explain somebody who doesn't have an inherent resistance to insulin? That is basically their cells are able to manage sugar pretty well. I was like, you must be overwhelming the system. So I have them actually go back and I go like, let's keep track of your carbs, keep track of your simple sugars.
Put a continuous glucose
Exactly.
monitor on them.
Increase your protein
I mean,
intake.
you
and let's see
can
if that
look at
changes.
someone's continuous glucose monitor, and you don't need an insulin resistance score. Their blood sugar does that, and it does that. They're insulin resistant. End of story. Especially if they're, have a fasting insulin in the teens or 20s.
Right.
You know that that's going on.
Yeah, because I was just going to say, I don't remember getting the insulin resistance score when I went to get my advanced lipid panel. I don't think
You have to ask for it. As I said, intentionally don't ask for it.
It's like, yeah, it's sort of stuck in.
It's not helpful to me.
Yeah.
So then how would somebody check their fasting insulin then?
You just check your insulin when you're fasting.
Oh, okay.
So it's
Fair.
and in fact, there's a lot of people have. I'll say, ask your doctor to check a fasting insulin, and not to cast aspersions on doctors' offices out there, but they'll look for fasting insulin as a test. I meant to say, I should have said, they'll be fasting for this, right? Yes. Check the insulin.
Right.
Because there's no such thing as a fasting insulin.
Okay.
Right.
I was assuming like a test.
Right.
Okay.
And
Well, it's a test
but-
for the level of insulin in your blood.
Right.
And it's most useful to measure when the patient is fasting, because it should be like my wife has this incredible 1.2 or 1.8, meaning I don't know if she's ever seen a carb a day in her life or whatever. but you know right away they're not insulin resistant.
Right.
Okay.
And you know, you generally would hope that your fasting or I'm going to start re-saying this, your insulin while you're fasting
Right.
would be like 6 or 7 or less. I think many doctors like us would like to see it under 5. And certainly when it's getting 8, 9, 10 and above, you go, oh my gosh, we got to do something.
Right. And a normal range, at least if I use LabCorp, which is kind of a national lab for the artists formerly known as fasting insulin, is about, I think it's like 3 to like 25. And so the other trick in interpreting it is you could have somebody who comes in who has a normal hemoglobin A1C. It's not going to be, it's going to be high normal, it'll be like 5.5 or 5.6. 5.7 and above is defined as kind of prediabetes. But if they come in and they have an insulin level of 26, you know their body is working really, really hard to maintain that sugar level. So they're in the process of developing an insulin resistance, and that is the cascade, and that is sort of the gateway to diabetes. Is that your body becomes less and less sensitive to the effects of insulin, so your pancreas has to make more and more of it, and at a certain point, it just can't.
So, you know, non sequitur, I don't think we were planning to talk about this today, but let's do. So I think that hemoglobin A1C is going to go by the wayside. It is just a very poor indicator of insulin glucose metabolism. You know, for example, I have several patients that have insulin in the 2s, that have fasting glucose of 80, and their A1C is 5.9.
Right.
Do you know why?
So I don't actually. I see this fairly often, and I tell people not
I know
to worry
why.
about
I
it.
finally know why. My 34-year-old daughter filled me in on why this is. Who's not a physician.
This is where
Any
the best,
guesses?
This
Any
is where
guesses?
the best. So when I see this with patients, and then I'll probably be proven to be fairly ignorant by responding, but I'm going to dive in anyway. That's never stopped me before.
Yeah.
I'll tell patients when I see this that there's probably a sort of a genetic set point. So like I think you're already smiling at me, but I've seen it in folks like
It's not that.
they'll have a parent with diabetes, and then their A1Cs will stay high.
Okay, so here's what it is. So first you have to understand what the hemoglobin A1C test is. It's how much, so the average red blood cell lasts 120 days. And so in that 120 days, you have this sugar in your milieu, the milieu of your serum and blood. If that level's high, then you're going to have more sugar attached to your glycation is the scientific term for sugars attached to a protein. You're going to have more glycated hemoglobin at the end of the 120 days. Anyone have any ideas why else you might have more sugar bound to the heme? Your red blood cells last longer.
Live longer. Okay.
So that's the obvious thing, is that there's and who, of course, is going to have red blood cells that last longer?
People training at athletes.
Super healthy eaters, people that don't eat carbs.
Right.
They're going to, their red blood cells probably lasting 130, 140 days. And then conversely, I've had these patients with insulins of 16 and they're, fasting glucose of 110 and their A1C is 5.3.
Right.
Because they're just... the red blood cells get born and they go, holy crap, so they probably have high red blood cell turnover. And I think that people that exercise and are healthy eaters, I bet you if you looked at it, their red blood cells last
Around longer. And it is, I think in terms of it going by the wayside, it is a lagging measure. So it is a 3-month average. So you're really looking back at 3 months. So whereas if you have a continuous glucose monitor, you're really getting real-time data.
Yeah.
And that's, obviously going to lead to more action.
And that's the other first clue. So several of these patients, before I figured it out, I would put continuous glucose monitoring, and you do an estimated average glucose and you convert that to an A1C and you do it and they're 5.1. Why are they saying 5.8
right
on it? And it's got to be that exponential.
That makes sense. Yeah. In terms of and even, because it's, not all the red blood cells are going to be, it's not like we pull out the ones that are 120 days old, right? There's 1 day old, and then, and potentially, you could see the average then skewing if you've got ones at 130, 140 days, right, just that have accumulated more sugar over their lifespan. It's interesting.
And it's also illustrative of why oxidative stress is so bad. It obviously, if your red blood cells can't handle it, the rest of your body can't handle it either.
Right. And then, and I think also too, it gives a sense of, really looking at things in multiple ways, and in terms of biometrics, which again, from a precision medicine standpoint, you're not relying on one measure, right? So you can look at LDL, you can look at the subparticles, you can look at, we haven't even talked about particle size. You can look at ApoB, you can look at Lp(a), you can look at, continuous glucose numbers, you look at fasting, insulin, right? So this idea that you're sort of, and, for diabetes treatment, we do focus on A1C. That's where the American Diabetic Association goals are in terms of treatment. This is where people should be. That's all well and good. But we do so much better than that. Looking at this in, I think you just rattled off, 4 different ways you could look at sugar. Yeah. And how people are handling sugar.
And the worst of them is A1C, and that's the gold standard. That's what's bizarre.
Right. Well,
I guess the gold standard would be the oral glucose tolerance test.
Exactly.
Who wants to do that?
Right, which they subject every pregnant woman to.
Right. And that's how it happened. My 34-year-old daughter happened to Madison. She was borderline. She was a little HIPAA violation there. And so she learned everything there was about how these different tests were measured and stuff. And I presented it to her. And she goes, yeah, red blood cells are living longer.
That's great.
That's another example of how people from outside of a field can look in and just tell you something totally obvious.
Right. Yeah, and it is.
I mean, we're smart guys. According to me, you're smart, and according to you, I'm above average. And I had no idea. I went for I go, dang, that is baffling.
Well, I mean, and this also too is something we've talked about this at least in our last podcast. You have to be open to stuff. I mean, I was very open.
Suggestible.
Right, to somebody bringing in an article from CNN, right?
Yeah. I don't know everything.
Exactly. Reminds me of that, the Cars episode with Tom Mater. I don't know if you may be too young to remember this, but he meets Finn McCool, who goes, Finn McCool, British intelligence, and Tom Mater goes, Tom Mater, average intelligence. I feel a little bit like Dr. Tomater right now.
I love that.
Classic wine.
Yeah. You want to ask a question?
Audience, ask a question.
Yeah. Oh my God. I didn't know we had a studio audience.
Yeah.
This is good.
Everybody gets a car.
Dr. Bretsky.
You get a car. You get a car. You get a car.
Under my chair, where's my prize? Going back to your case study, which was fascinating, you talked about how it kind of came on overnight, basically at 70 years old. Mm-hmm. Do you do a deep dive into, what they might have been exposed to, like the metals, or they may have traveled that would just...
Did they listen to AC/DC? Is that what you meant?
Exactly. Or taken AC/DC somehow, get electrocuted, or something that would have jarred their body system?
Yeah, I mean, that's an interesting question. I hadn't really, my assumption was sort of an accumulative effect. I mean, obviously,
but it's really kind of a point mutation.
Yeah.
It's so codon 41. It's a single amino acid. Usually means it's a single base that got picked off. So I mean, I think that is always a really interesting.
Did you, as a rule, measure metals at all in one system, or?
So we'll look at heavy metals. Again, that's sometimes a little hard to sort out, just because it's like
it could be what you ate yesterday,
right?
Or like maybe he was really intrigued or like really excited for his food to be warmed up, and he just stand in front of the microwave.
But this is where the whole genome sequencing and whatnot can come into play, and we haven't really gotten into that as much as we'd like to, but. One of the things that may be the culprit per se, we all have mutations happening. We just got mutated. Everyone in this room just got mutated in the last Number one, hopefully it wasn't a tumor suppressor gene.
Right.
Hopefully it didn't get both. It's usually not going to get both copies. But you have mutations, but then there's these DNA repair molecules we all have that's going around and repairing that DNA. Or if a cell starts behaving poorly, if you have a good functioning immune system, it goes and takes it out. So you can assess someone's overall risk and tendency toward cancer by looking at some of these other genes that you're born with, so to speak, and what you may have variants there. So ultimately, it would be interesting to look at these cases and look at polygenic risk scores see if there's a correlation between a tendency toward cancer. I would be concerned this guy might have a tendency toward cancer, not only because his body didn't repair this mutation, but also being exposed to this inflammatory state like he's been. I would pan scan him, so to speak. I mean, I would do, the usual. I would be very aggressive about colonoscopies, meaning like every 3 or 5 years instead of 10. I would do a lung cancer screening. I would be looking at his PSA very carefully and velocities and all that kind of stuff.
Right. And it would also, too, the whole
Gallery test.
Right.
And that was the other thing that occurred to me. I wonder if there's any methylation pattern changes that occur with this. I would love to see what a gallery test would do with this.
Yeah, and to your point, I'd be interested, like in check 2. These are some of the, sort of the, repair and surveillance kind of genes that are, got to be germline mutations as well. But we'll see check 2 mutations in folks that have had like multiple different kinds of cancers and stuff like that, trying to kind of piece that together.
In the medicine of the future, you're going to be, which is now for us, especially you'd be able to use the Biography Health platform to upload all this and leverage AI and look at all the significance of these genetic variants, et cetera. You're going to want to be doing this. You're going to want to be connecting these dots. You have to put a little thought in and know where there's additional risk.
2 more follow-up questions.
Oh, please.
With the polygenic risks analysis, do they ever incorporate lifestyle as part of the mix?
Yes.
They do.
So we call those integrative risk scores.
Okay.
So there is polygenic risk, which is, I saw talk about a case I did yesterday. Someone has, this is a good case to talk about. So she has an aunt on one side, on her father's side with breast cancer, and a grandmother on her mother's side with breast cancer. So what's her risk? Did she inherit that risk? And these are not BRCA or single gene type smoking gun type mutations that cause these cancers. They were both, well, actually one of them, I think the aunt was in her 30s or 40s and the grandmother was in her 60s. But what's interesting about it is her father's still alive at 95 and her mother's still alive at 97. So they obviously likely didn't inherit cancer risk. And the question is, did she somehow inherit it? And we look at her polygenic risk score for breast cancer, and it's about average. So, but to get at your question, though, when we look at her integrated risk score, it's sky high. It says she has a 50% lifetime risk of cancer. But what's wrong with that? This just goes to show you, like with the hemoglobin A1C, you got to know how the test is done. So that test is not really completely accounting for the fact that her mother and father didn't develop cancer. So you see what I'm saying? So that has to tell you that there's, that has to modify the risk associated with having 2 second-degree relatives.
Who may have smoked.
And so if you look at, may have had other risk factors for cancer like obesity, smoking, hormone exposure, et cetera. So you have to be just very thoughtful about this. And anyway, so to answer your question, their polygenic risk scores on their own. I'm doing this because it's a one-tailed curve. And are you average risk, high risk, low risk? You do look at that. But then when you integrate these clinical risk models and risk factors into it, you have to be very careful about how you do that.
Right.
That's so cool. Can I ask one last question?
Yeah. I was just going to follow up a little bit on that as well too. Yeah, I mean the hormonal component of breast cancer risk is very well worked out. Actually, there's a group at USC that sort of figured that out in a really seminal paper where you're looking at the modifiers of a woman's hormone exposure over the lifetime, and so that would be like age of menarche, which is when you first had regular periods, age of first full-term pregnancy. If that's delayed, that increases your breast cancer risk. If you have a full-term pregnancy when you're younger, that modifies it as well. Obviously, age of menopause, and as you mentioned too, the role of oral contraceptives, and then the role of hormone replacement therapy. The formulations of those have changed tremendously, certainly since the 1960s, as well too. So you really have, obviously you have the genetic component, and then, you have these other, sort of semi-modifiable risk factors in there as well. So it actually gets to be this really sort of interesting mix of things. And at the end of the day, when somebody's like, well, wait, what do I do about it? The biggest preventive thing that you can do for not only primary prevention, but secondary prevention of breast cancer is exercise.
Yeah.
So, which Leslie Bernstein, who's also at USC, also figured out in sort of this, this study of women that had already had breast cancer and then looked at how do you prevent a recurrence. So it gets, again, it's really sort of interesting, in the same way we talked about in terms of some of the biometrics, look at it in a bunch of different ways.
Right.
But you'll probably end up in the same general, not to use, I'm stealing your term, same general milieu.
Well, I didn't get the French accent on it, so I lose a point.
I had to spruce it up a little bit.
I do have now I have Betsy a follow-up question. Yes, I'm a 61-year-old woman, and I'm surprised now that I'm learning more about hormone replacement than going back to birth control. There's not a lot of discussion, at least I haven't experienced that, where people talk about, keep in mind when you go on this hormone replacement that this is going to significantly bump up your risk for breast cancer or uterine cancer. And that's always been my concern, is weighing out the risks and benefits.
Right.
And I feel, and some doctors do just mention it, and it's kind of generally known, be careful, ultimately estrogen but I'm surprised it's not.
Well,
Not conversation.
can I address part of that? So, I mean, part of that is why you want to have a good understanding of your underlying genetic risk and look at it in the context of the other clinical risk factors. So in this case I'm talking about yesterday, this one risk model based on having 2 second-degree relatives with breast cancer, even with her average genetic risk, just knocks it way the heck up. And she is on hormone replacement, a small dose, and has, I mean, you're familiar with the range of estrogen for, it's like what, 0 to 60 or 0 to 40. Hers is 10. And she loves it. She loves being on hormone replacement. So do I tell her, stop? Oh, no, you definitely have to stop that. It's more complicated, so and can you compensate for whatever minuscule, probably increased risk from that low dose hormone replacement, which she loves, with better screening. She has resources to even with, if insurance isn't going to pay for it, and she's very careful. In fact,
Plus the cardiovascular benefits you get.
The bone health, brain
density.
health.
Yeah, exactly.
And a whole nother episode.
It's a whole other podcast.
Another episode would be discussing the Women's Health Initiative, etc.
So what has been helpful for me in my time college OB-GYN, I have provided her with a list of my risks and where we got them from. Be the integrative, the polygenic, or I know I don't have the monogenic BRCA, but when they looked at I believe it was my polygenic or my integrative, it came out 29% based on my aunt and my grandmother. Aunt smoked like a chimney, but they didn't really, that's...
And keep in mind, even with that, 29% is only twice the average.
Right. So
the average is abhorrently high, the average risk.
Right. Yeah, I think the population expectation is like 14%.
Yeah.
For a woman developing breast cancer in the lifetime.
And my OB-GYN found it very helpful. We went down my list and concerns, in our action plan, and it was fantastic for me. But I did want to go back to your case study and ask you about the
lipoprotein little, what is called LP little.
There's nothing you can do about it because you're kind of born with it as of now.
Right.
But would that help you know if it were environmental or familial, or what did you call it? Born with it kind of thing, at least as a starting point for trying to go down a path of figuring out what this is. I mean, that would be an important piece to just 50-50, right? To decide, let's start with this, and then we'll go down this path if we know it's...
So it's not really an environmental one. It's you have the gene for it or you don't.
Right.
That's why you only check it. If it's low, you only check it once.
Right.
You never have to check it again.
To know if that's there, right?
Oh, for sure.
Yeah.
Absolutely.
But that leads to another question. So is this guy on a PCSK9 inhibitor?
Well, yeah, I mean, so we got him, again, this is sort of acute phase, chronic phase, right?
Yeah.
So we got him stented. But yes, no, I mean, the one thing that has been shown that we have available to us currently is PCSK9 inhibitor, which will reduce it maybe by 20%. Alternatively, many of the clinical trials, now he's had basically documented coronary artery disease.
Yeah.
And so, now, and if you're in a clinical trial, you could be in the placebo group or you can be in the treatment group. It's funny because sometimes I'll have patients say, well, why would I do a clinical trial if I might not get the medication? And I was like, well, if you don't do the clinical trial, your likelihood of getting the medication is 0%. If you're in the clinical trial, it's 50%. And also, too, some trials are what are called crossover trials. So somebody who's in the placebo will then cross over into getting treatment as well, too. So, but yeah, I mean, I definitely, coming out of this as we get him, recovered from the stenting and things like that. I think we would do a PCSK9
because it would have some effect. And it would really whack the other ones too.
Absolutely. Yeah, I mean, they're quite astonishing. Like when you look at like the traditional lipid panel of folks. I mean, so generally for somebody at high risk or has had an event, you're shooting for an LDL under 70, which is not impossible.
And for someone like this, you'd really want them under 50.
Right. And and that's, not impossible, but hard to do even with sort of max dose statins. But I've had patients that'll go on these that I'll get an LDL of like 15.
Yeah. I had a patient 7.
And I think you're sort of looking at that, you're like, surely you must need some LDL. Maybe not.
Well, Peter, of course, that gets talked about a lot. Peter Libby, the lipidologist at Harvard and whatnot. Anyway, if you listen to those guys, they think there is no such thing as too low.
Right.
But it is kind of scary to think about. Yeah. And they talk about how little of your cholesterol is actually circulating in your blood compared to what's attached to your cells.
Right.
And that really the concern would be total body cholesterol, not just what's circulating.
Right.
Day one of this diagnosis or the symptom.
Right.
How long has it been this journey?
So basically it's been about 2 years for the whole process. Just kind of getting everything stabilized kind of took about a year. With the hemoglobin of 7 and an allergic alveolitis, this is somebody who's in the ICU.
This guy's lucky to have his wife and you, especially, to come up with this diagnosis and really somebody's, pursuing the coronary artery disease angle aggressively. I don't think every doctor, certainly not every doctor, I don't know if many doctors would put that together and be that aggressive.
Yeah, and I think also too, one approach I kind of take with patients is I never know where a good idea is going to come from. And certainly this is a case where we were flat out of good ideas at that point. I had sent them to, oncology and rheumatology and really, very, people I've worked with a long time who know a lot. And when you're up against something, there's been 58 described cases, there's obviously a large knowledge vacuum, but you, like I said, going into these things, you really have to be open to where you're going to get information from.
Right.
And I was like, well, that's as good of an idea as any, that we've had. And then you just pursue it to a conclusion.
And a lot of times when you start pursuing down pathways, it opens up other pathways.
It does.
Would you say that this has been your most complex case?
Probably not.
Internal medicine.
That's okay.
This is not family medicine. I'm not casting.
No. Yeah. The complexity of case, although this is on that axis, because where the complexity in cases really becomes is when you have multiple things going on. So here I think there's kind of two major things going on, right? We have this, auto-inflammatory syndrome, and we have heart disease. There's not, high blood pressure, there's not diabetes, there's not, cognitive decline. But where things get really complicated is when you've got about 6 or 7 different things, and then the treatment of one could impact, sort of the other. And that's where stuff gets really, really complex. But that's kind of the cool part of internal medicine is that, on one hand, you have somebody come in with a, strep throat, and then you have somebody who has sort of 7 cascading things, and that's what makes it fun.
Is this going to be? I was going to say, is this going to be a newsletter article?
So potentially. Well, it'll be a newsletter article. It's so, as Bill pointed out, it's so rare. I try to, in our newsletter, I try to do stuff that's a little bit more common. But I think, in the newsletter, I've had discussions of LPA. Right. LP little a. And we call it LP little a because it's LP and then it's in parentheses little a. And so that is something that I think is sort of more useful in terms of kind of moving in terms of a general patient population. And I think that people should know what that level is because now, in 2 years, there's going to be something on the market for it.
For sure. And this is really just a nice little call to action saying, go to subscribe to Dr. Bretsky's newsletter. It comes out every month. Great articles.
It's great. I love it. I look forward to it. I'm waiting for it to drop every month.
Yeah. December, I've had some ideas for the December one kind of already. And I may just, as things kind of move forward, I may do it a little bit more often, especially as there's kind of flux in the CDC and National Institutes of Health and
flux is a kind word there. You mean when someone takes the jar of marbles and dumps it out? Yeah, I like that.
And
that kind of flux.
Exactly.
You guys are like brothers.
Yeah. We spend a lot of time together.
So he's the better looking one. It's twin sons of different mothers.
How has your PhDs, your both MD PhDs, influenced you, or has that helped you with your precision medicine pursuit?
It was funny when so my PhD is actually in genetic epidemiology, but I have a background in infectious disease.
What was your undergrad again?
English literature.
English, yeah. and your parents are like PhD geologists,
Yes,
right?
yeah. So,
I love his background. Anyway,
I was, my first sort of real job was my dad's field assistant. So, which I basically carry rocks. Actually, I never thought I'd really use this sort of epidemiology. With COVID, it became super useful because, I sort of knew, how to navigate a respiratory.
so you have a separate degree in epidemiology from your PhD, right?
Yeah, so I spent a lot of time in school. So I have a master's in public health. When that was infectious disease.
I see.
Yeah, so I actually, my
Okay, good.
master's thesis is on raccoon rabies. So
I hate raccoon rabies. I mean, it's the worst.
But in terms of, I think to answer your question, now that we've sort of significantly digressed, the PhD aspect of it, I think the process of going through and understanding sort of scientific inquiry and then is really helpful in terms of the precision medicine aspect. Because I think traditionally people will sort of point to kind of like a seminal paper. They'll be like, okay, this is the answer. And when you've really delved in a PhD and gotten really into the weeds in something, there's no seminal paper.
There's no such thing as
Right.
the answer.
Right. I mean, I think other than like, Einstein's theory of relativity, I mean, and I'm not even joking.
Or like double helix.
Right. There's not
More or
really
less.
a seminal paper. So what you understand is there's a lot of nuance in stuff. And when you're really and you become a de facto expert in what it is that you're getting your PhD in, there's dozens of articles that you read, and some of them can be really obscure and quite good as well. So I think from that standpoint, that helps because, again, one of the things I think we talked about in this podcast is like the multiple lines of evidence to get to a patient outcome, right? And whether it's, fasting insulin, whether it's a continuous glucose monitor, whether it's their, somewhat flawed A1C, you become comfortable with this idea that there's not like one thing you're looking for, which I think is a trap a lot of people fall into.
And I think the PhD helps you have just a fund of knowledge, so to speak, about basic science.
Right.
Like, how does this actually work? I mean, none of us knows, of course, but we can, I think if you've gotten in there and pipetted and run gels and all that, you realize just how complex it is and how many pathways. And so, that opens up your mind, but it also, as you say, you quickly reject simple answers and the elegant hypothesis. Right. My PhD mentor, Linda Deemer, told me, what's the problem with an elegant hypothesis? I go, no, what? She goes, they're always wrong. I'm like, oh, yeah. Linda, who's still alive.
She's right here. She's right here. She's not up there.
Yeah. And I think for me, the engineering background, for having an engineering background, you get, and I think even if you had a geology background or any kind, you're used to solving problems. You're used to taking, information from different places. If you've ever worked on your own car, those are the people you want to be your doctor. Right. Because you have to look at a lot of different systems. What's that sound? Now, what's that look like? Is that supposed to go like that? And you have spent hours and hours as a kid or teenager trying to solve, trying to fix what's broken or find out how to make something so it doesn't break. And that's exactly what doctors do.
Right.
We are way over time on this, but I really appreciate you, Dr. Bretsky.
Yeah.
Dr. Stanford, you're always here as a co-host. But can't wait for another episode.
Yeah, it's fun to be in the same room. This makes it like 10 times
in-person
better.
ones are the way to go.
Yeah.
And so, links will be at the end or in the show notes, and then also a link to his newsletter as well. Can't wait to have you back for another
What
episode.
about my book? You didn't mention.
Oh, yes. Yeah. And your book. This is a great time to talk about your book.
We don't have to talk about it.
Just link in the
Implementation of personalized precision medicine.
Yes. I feel like that should be a whole other podcast episode.
No, it won't be, but
Each chapter could be one.
Oh, I have to, when I get the book, I'll have to hold it up.
Yeah. But anyways, thanks everyone for listening. And this is actually the first time having a live studio audience.
It is cool.
Yeah, it was fun. Yeah. But anyways, thanks everyone. Signing out.
Thank you. That was really fun. I hope I can get a signed copy of it.
Yes.
Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.